Assessment and management of head injury is extremely important, and it's a clinical skill to identify head injury at an early stage. So, what should we look for when we assessing a patient suspected with a head injury? First thing, the surface findings. So we have to observe the patient thoroughly. We have to assess the patient thoroughly. So look for any scalp lacerations. So there can be torrential bleeding from scalp lacerations. So look for that, and we need to stop bleeding if necessary. And feel for any skull fracture depression. Don't palpate, push your skull, broken piece of skull into your brain. So just feel for any skull depressions or fractures. Look for any facial bruises or contusions, because face is one side of your brain. So if there is a facial fracture, there is a high chance that patient might have had a head injury or basilar skull fracture. Look for battle signs. Battle sign is bruising behind the ear. And look for raccoon eyes. Raccoon eyes means bruising around the eyes. So I have some pictures for that. So this is the battle sign, as you can see, bruising behind the ear, and raccoon eyes, bruising around the eyes. In respiratory assessment, we look for, is there any hyperventilation? There is always a chance of central neurogenic hyperventilation in case of a head injury. Look for chain stalk respiration. Most of the patients with a head injury can exhibit chain stalk respiration. That means breathing with varying depth. High depth and low depth, it will be varying. So there will be a period of high deep ventilation, and then come back to low shallow ventilation, then go back to deep ventilation. So that's a varying pattern of breathing. So that's the chain stalk respiration. So look for, is there any sign of chain stalk respiration? If there is a decreased oxygen saturation, always treat it, because in head injury we always aim for high oxygen levels to keep the brain tissue, to help the brain tissue to survive. Look for bradypnea. That's a very bad sign. If the brainstem is involved or midbrain is involved, there is always a high chance patient's respiratory centers can be depressed and can cause bradypnea. So always look for that. When it comes to the CNS assessment, look for pupils. Pupils gives you a lot of information, especially if there is a intracranial pressure is shooting up, pupils will show that. So if the pupils are unequal, or pupils are fixed and dilated, or pupils are not reacting to light, then that's a warning sign. Is there any asymmetric facial movements? Look for any signs of paralysis. Any when ask the patient to smile, and if the patient smiles, when the patient smiles, lip goes to one side. That means the other side is paralyzed. So look for those kinds of asymmetric facial movements. Is there any, look for the neurological status? That means the patient is alert, oriented, or if the patient is abusive or confused, any kind of neurological deterioration, have a look. Is there any level of consciousness is reduced, or is the level of consciousness is fine? Is a look for GCS score. If the GCS score anything less than 8 is very, very critical, patient needs airway management. If the GCS score less than 12 is considered as like sign of head injury, if head injury is suspected. So look for any kind of neurological deterioration, including behavioral deterioration, because if the patient has a sudden acute confusion or delirium, that shows your brain has some issues. So always look for acute sudden changes in behavior or neurological status. Look for bowel and bladder status. So if a patient who is not incontinent, suddenly having incontinence, there can be a spinal issue or an issue with the brain. And look for muscle flaccidity. Look for any hyperactive or decreased reflexes, any decerebrate or decorticate posturing. Decerebrate posturing, cerebrate, extension. So in decerebrate posturing, the patient will have joints will have extended, all the limbs will be extended, and in the decorticate posture, just opposite limb will be flexed. So decerebrating posture is the worst thing that you can have. So always look for decerebration, decortication. Okay, look for ear and nose. Is there any discharge from the ear? If is there any bloody discharge or a clear water discharge from the ear. There may be a blood leak, that means indicates the basilar skull fracture. Any CSF leak, clear fluid discharge from the ear or nose, that can indicate there is a head injury and skull fracture, especially basilar skull fracture might have happened. Is there any seizures? That's another sign of injury to the brain. So look for all these signs and symptoms, and these assessment findings will help you to look for to confirm whether the patient has any head injury. When it comes to the initial management, the first thing always take priority is the airway. So look for airway. Is the patient able to maintain his own airway? If the GCS is more than 8, most likely patient may be able to maintain his airway. If the GCS is very low, I have to put an oropharyngeal airway. If the patient is alert, but maybe patient may be very drowsy, but still the patient is rousable, you need to put an nasopharyngeal airway unless there is no basilar skull fracture. If you are suspecting any basilar skull fracture, if you see battle sign or raccoon eyes, or if you see any discharge from the ear or nose, don't put a nasopharyngeal airway. Nowadays, it's not contraindicated, but it is extreme caution. It used to be contraindicated, but now we use extreme caution before putting nasopharyngeal airways in suspected head injury patients. But maintain the airway. Advanced airways like LMS and intubation will come into place once we have QAS paramedics arrived. So airway management is a key thing in a head injury. Look, if there is a head injury, there is always a chance that cervical spine may have an injury. If you suspect a cervical spine injury, always immobilize the spine and take spinal precautions when you assess the patients and when you manage the patient. So if you need to turn the patient, always do log rolling. That is extremely important to prevent further spinal damage. Because if the cervical spine is injured, there is always a chance that the phrenic nerve that comes out of the cervical spine can be damaged. If that happens, patient will suddenly stop breathing because diaphragm is supplied by the phrenic nerve. So always look for and stabilize the cervical spine if a cervical spine injury is suspected. If oxygen level is less than 96, I would recommend give oxygen through 100% non-rebreather mask, because in this scenario, head that priority will go to the head and brain tissue. So survival of the brain tissue needs more and more oxygen, because when the ICP goes up, your cerebral perfusion will be impaired. So we need to give more oxygen to the patient. So always keep an eye on the oxygen. Recommended is 100% rebreather in the initial stage. And establish IV or IO access, 2 large bore IV cannula indicated. And is there any scalp laceration bleeding? Control any external bleeding. And if there is no C-spine damage is suspected, elevate the bed, head of the bed to 30 degrees, because that will improve the venous drainage and potentially reduce the intracranial pressure and cerebral edema. So, but if the cervical spine injury or any spinal injury is suspected, keep the bed in a neutral position. You can still tilt the whole bed, not just the head or leg. Tilt the whole bed slightly up to improve the venous drainage if you suspect any spinal injury. When it comes to the ongoing monitoring, keep patient warm. Hypothermia is very common in head injury, and that hypothermia will be very difficult to revert. So always keep the patient warm using blankets, warm IV fluids, warming lights, or heated and humidified oxygen, whichever way we can keep the patient warm. And monitor level of consciousness. Any change in the level of consciousness is key. That means the patient is deteriorating, brain injury is getting worse, and intracranial pressure is going up. Look for O2 saturation, because we need to keep the saturation high to make sure the brain is not starving for oxygen. And look at the pupils and GCS level constantly, because any change in the GCS or any change in the pupil reaction indicates a increasing ICP. That means worsening head injury mechanism. So we need to act fast, and so keep an eye on that. Administering fluid is very cautiously if you need to, because more fluid can cause more cerebral edema. So always be cautious if you are choose to administer fluids for hypotension or something like that. Always keep an eye. And always anticipate intubation and advanced airway for a patient with a head injury, because they can deteriorate very quickly. So always be prepared for intubation, especially assist the QCS team or QAS team to intubate once they arrive. Okay, so when it comes to the assessment, a level of consciousness, the primary assessment method is ABPU scale that everyone knows. You look for alert. If the patient is alert, that's A, that's well and good. If the patient is not alert, if the patient is responding to voice, that is V. Okay. If the patient is not responding to voice, gives a pain, you can do a trapezius punch or just press the nail bed and see is there any response to pain. If there is no response to pain, that means the patient is unresponsive. So this is one of the simplest but very valuable scale which you can use when a patient with a head injury. If you want to know a detailed scoring, you need to do a Glasgow Coma scale. Everyone must be familiar with the Glasgow Coma scale. Maximum score is 15. Anything below 12 is critical. Anything below 8 indicates intubation or advanced airway. Okay, so in the respiratory pattern, like always, disturbances in the respiratory center in the brain will cause chaotic respiration, mainly chain stalk respiration. So look for difference in the breathing pattern, and if the breathing is affected, most likely there is a injury mainly deeper into the brain tissues, mainly in the brain stem. Okay, so if chain stroke respiration, that suggests lesions deep in both hemispheres, and if it's a hyperventilation, that suggests the patient has brainstem damage. If the patient is having bradypnea and bradycardia and hypotension, that indicates the patient has very high intracranial pressure, and patient may be having brainstem herniation. Okay, look for the pupils. Unequal pupils suggest increased intracranial pressure, and a progressive dilation of the pupils indicates increasing intracranial pressure. Fixed and dilated pupil indicates the midbrain injury. That even once the patient is dead, their pupils will be fixed and dilated. So always look for these bad signs. Look for corneal reflex. The corneal reflex, you can take a cotton or gauze and you can touch the cornea to see is there any blinking happens. So that's a test for cranial nerve 5 and 7. And usually in a head injury patients, when they go to the ED, the clinicians will perform a detailed cranial nerve assessments. So that gives us an idea, even without scan, that gives us an idea what level is the damage. And facial asymmetry, that's another thing, as I mentioned. Look for any signs of paralysis, any power difference between both sides, or any facial asymmetry. Swallowing, that's another thing. If the patient is alert, you look for any signs of drooling, because if cranial nerve 10 and 12 are involved, glossopharyngeal nerves are all involved, the patient cannot swallow the saliva and they will be drooling. Look for dysphagia if patient is alert, and see for any signs of difficult swallowing. That indicates again head injury. These things won't happen and come in coma stage if they won't have any swallowing in the coma anyway. So stiff neck, that's another thing. Stiff neck indicates issue with the meninges. Is there any, in case of any subarachnoid hemorrhage or any meningitis, that's the time. Whenever the meninges is affected due to bleeding or due to infection, the neck will go stiff. So stiff neck is a key thing to assess for. Okay, look for deep tendon reflexes if you are trying to do so. Any brisk response in the deep tendon reflexes, hyperactive, that may indicate a localizing injuries, and any asymmetric response will be seen in paralysis, and in comatose stage, deep tendon reflex won't be there. Look for any pathological reflexes, mainly Babinski reflex. The fanning of toes. Babies, when you tickle the heel, then the toes will fan normally in kids, in babies, infants, and we flex our toes in adults. But if the fanning happens in adult, that indicates head injury. That's a pathological reflex. Look for decortication. Is there any signs of abnormal flexion? Decerebration, any signs of abnormal extension? So these are the key assessment things we are looking for when you assess a patient with suspected head injury. What you can do diagnostic wise, as usual, we can do an X-ray of the head and see is there any skull fracture or massive bleeding or hematoma. We can do a CT brain or to see is there any changes, any hematoma, any stroke or anything like that. A CT angio we can do to rule out bleeding and ischemic stroke, and we can do an MRI for a detailed picture, and we can do EEG for measuring seizure activity and brain activity, and we can do a lumbar puncture to take the CSF and do some testing. If the blood in CSF indicates fractures and head injury, and if the CSF is like having high protein and sugar and things like that, indicates an infection. So management wise, like in our setting, we don't manage head injuries. As soon as we identify and diagnose a patient has head injury, we stabilize and transfer the patient. But if you're looking for the management based on the cause of the head injury, is it acute brain injury? If it is due to infection, we treat with antibiotics or antivirals if it's viral, antifungals if it is a fungal infection. If there is a hematoma, a surgical evacuation is another option, or in ED the surgeons or ED physicians will drill a burr hole to drain out subdural or epidural hematomas to reduce the intracranial pressure. These are all emergency management happens in a higher center, not in our facility. And increased ICP patients in neurocenters, they can monitor intracranial pressure. We can also see the difference in the blood pressure. If the blood pressure keeps shooting up, that means intracranial pressure is going up. So we can also estimate intracranial pressure. To accurate measurement, we need to cannulate the brain to get the intracranial pressure monitoring. If there is any tumor, anyway, surgeries are indicated for tumor. So in QA, like in COHS point of view, assessment is a key thing. We assess the patient, and we like identify head injury, signs of head injury. We look for it, and we identify the early stage, and we stabilize and transfer the patient. That's our responsibility. So our key skill we need to develop is assessment for head injury. And if you have a in your assessment, patient is fine, but patient has a possible mechanism of injury, but you don't feel like is there any head injury. So what you can do, you can give some advice to them, like any change in the status, any change in the neurological status, any new onset of confusion, or any delirium, any behavioral change, or any nausea and vomiting, because usually the bleeds, hemorrhages in the brain can cause nausea and vomiting, because vomiting center is situated not in the tummy but in the brain. So ask the QCS staff and the patient or patient's roommate to report any kind of changes in the patient. So that's the best advice we can give. And if any changes, we assess them again, and if needed to transport the patient to the hospital, we do. Okay, so that's the key things, key take-home points in brain injury assessment and management. Okay, thank you for listening. We'll see you with the next topic. Thank you.